Today we're going to be covering Chapter 11, looking at women's health issues. So beginning with looking at some gender issues. Worldwide, being born female is dangerous to your health. There are specific conditions that are much more common in females than males. There's also many issues with females not receiving appropriate medical care that they should. Although males have a higher death rate than females. If you look at life expectancy, women are expected to live approximately 5 years longer. But gender makes a big difference on the types of health problems that people experience. It also makes a difference in the way disease is diagnosed, viewed, and treated. We'll look at heart disease as a specific case of this. And this is an important part of many women's experience, which is why we cover it in this class. Women have often been neglected in medicine and medical research. With the history of medical research, women were excluded for a variety of reasons, one being protection. And so oftentimes the research is done just on men. There are also a number of gender stereotypes that are common in medicine. For example, women are more likely to complain, and so oftentimes when they are trying to receive medical care, they get written off as overreacting. Sometimes medical care can actually be completely irresponsible and is oftentimes inadequate. Physician-patient communication patterns often make women feel powerless. That power dynamic makes women feel like they can't question the authority figure, and so they don't really speak up for themselves in their medical care. Now, to try to change how research studies are done to try to include more women, there's actually been a law passed by the National Institute of Health to include women and minorities in all clinical research studies, including Phase 3 clinical trials. Now, Phase 3 clinical trials are where they're looking at the effectiveness of medication. That's why it's important as opposed to other types of clinical trials. Cost is not an allowable reason to exclude women from research. The National Institute of Health wants to recruit more women, minorities, and subpopulations in clinical studies so that we can find out for real how medications and how medical illnesses actually affect women and minorities differently than it may affect men. Like I said, it was originally thought to be protection of women that excluded them from medical research. There was a lot of historic abuses of human subjects in the 50s and 60s. There was also a lot of adverse outcomes in children of women who had taken certain drugs. So because women can become pregnant, there was concern that taking medications and research studies could possibly affect an unborn fetus, and so they created regulations to try to protect these unborn fetus. In the 1980s, there were some challenges from women health groups and AIDS activists that said these policies were overprotective and overly exclusive and was leading to too many women being excluded from research, giving us lack of data on how medical diseases and medications actually affect women. A report said that there was a failure to implement in 1986 policy on the inclusion of women in clinical studies. So even though they tried to challenge this, there was a policy in 1986, it did not actually put women into the clinical studies as they were supposed to. So a new act was passed in 1993 to try to include more women as well as ethnically and racially diverse groups of individuals for research participation. Some other ethical considerations are some unconscious biases. This can influence the topics that are selected. So researchers who have these unconscious biases against women may choose topics that implicate women as being weaker or focus much more on men's issues. How the topics are operationalized, and we've already kind of looked at that before with when it comes to how, for example, women tend to have undervalue themselves and men tend to overvalue themselves, how do we operationalize that? Do we operationalize it as women undervaluing or men overvaluing when we see these differences there? How they design the studies and collect the data can also affect the results, leading us to bias information, and of course the participants who are chosen. We tend to see a male bias and a male norm for research studies classically. More recently that has changed, leading us to have a lot more information about women. These are some diseases or conditions that tend to impact women much more often than men, including things like migraines with aura, carpal tunnel syndrome, a whole host of autoimmune diseases including rheumatoid arthritis and lupus, other gallbladder and irritable bowel, as well as obesity. So knowing how these diseases affect women more than men, the women really should be included in the research to study any medications used to treat them. Now, life expectancy, I mentioned, men tend to live longer than women, but even that is somewhat, biased and not really looking at how different racial groups also interact there. Intersectionality actually affects life expectancy, and years of education also impact it. You'll notice that African American or black males tend to live much, much longer lives when they have completed high school and some college. And life expectancy tends to go up for all groups with higher education. But there's a huge discrepancy in life expectancy depending on which racial group you're a part of. This is life expectancy across the world, and I included this graphic because I think it's pretty neat because you can see all of the differences in different continents and across different countries. And you can see that male and female life expectancy is different in different nations, with Monaco having the highest life expectancy for both. United States is up there, but still not in the top group of countries. In the middle range, we see the Eastern European and some of the Asian countries, as well as many of the Middle Eastern countries, and some of the lowest life expectancies in African nations, as well as Afghanistan. Afghanistan has some of the lowest life expectancy rates, and they are the only Middle Eastern nation that is there at the lower end of the spectrum. So, next thing I want to look at is income level and how that can affect health. We looked at educational level and impacting life expectancy. One of the pieces of that is the lack of income. So take a minute and think about what are some of the factors associated with low income that can affect your health. Some factors include, if you didn't think of these, are poor nutrition. It can affect your health, as well as lack of access to medical care, preventative medicine. Now, a lot of people have concerns about the Affordable Care Act, and just wanted to let you know some of the things it's done to actually improve things for a lot of people, including making it illegal for insurance companies to put a lifetime cap on how much they will pay for you if you get sick, or cancel your coverage when you get sick by finding a mistake on your paperwork. This actually used to be a job at health insurance companies. If someone got diagnosed with cancer or HIV, very expensive diseases to treat, their whole job was to find loopholes in their paperwork to try to make it so that the company didn't have to pay. It also helps to get access to a lot of preventative services for free. Cancer screenings like mammograms and colonoscopies, vaccinations, blood pressure screenings, even tobacco cessation counseling to help you quit smoking. Now, this preventative services can help to improve life expectancy and health overall. And for women specifically, it also includes free services for well women visits, so that annual exam where you go in and get your pap smear and get checked for breast cancer, and also mammograms and HIV counseling. All of these things can help to keep you healthy, and it's nice to see that contraception, birth control pills are also now being covered by health insurance, whereas they didn't used to be. Before, small businesses paid an average of 18% more for health insurance than large companies, and today small businesses can get a tax credit to help pay for coverage for their employees. So one of the big things that people say is that it was going to hurt small businesses, but it actually helps them in a lot of ways. So I mentioned heart disease as an example of how diseases look different in men and women. Now, heart disease actually affects women very differently than it does men, and part of this is due to the effects of estrogen on cholesterol. Overall, heart disease tends to be a silent disease. It's not necessarily something that causes you pain or discomfort, so it can go undiagnosed if you're not going in for regular checkups. Women tend to manifest heart disease 10 years later on average than men, so it hits them later in life. Their heart attacks often are more likely to be fatal. They also have different symptoms and signs, whereas men, they talk about the paralysis and pain going down your left arm. For women, it can be pain in different areas, and sometimes women are misdiagnosed as having an anxiety attack. Women are much less likely to receive the interventions. Part of it is lack of access to medical care. And because of the gender bias in the medical research, we didn't know a lot about how heart disease and heart attacks manifest in women. And we're also learning more about how the medications may help women differently than they do men. Now, discrimination when it comes to health care, it can lead you to have high blood pressure. It's a typo there. When you feel discriminated against, it can create that stereotype threat, which can cause you to have higher blood pressure when you go into the office. But if you're experiencing it on a regular basis, this chronic stereotype threat can keep your blood pressure elevated all of the time, creating this chronic stressor for many women. So overall, feminists have been pretty critical of the treatment of women in the healthcare system. Often women are considered subordinate in status, at least in our society overall, and we see that physician-patient relationship kind of mimics the subordinate status, leading women to kind of feel like they don't have a voice in their own health care, that they're not heard and not respected when they're in an office seeing a doctor. And the medical profession has actually actively discriminated against women doctors and getting women physicians in the field, which could lead to some women feeling like they're being more respected by their doctor when they can see a doctor like them. And overall, women have actually described their medical care as being uncaring, that even at times completely irresponsible. For example, 70% of hysterectomies where the uterus or more of the internal reproductive system are removed are completely unnecessary. And medical research, as I've said, is often missing, but sometimes is completely irresponsible as well. Now, poor and ethnic minority women have higher rates of infant mortality than white women. Part of this is due to poor prenatal care, not receiving it because of cost, also because of discrimination and how they're treated by the healthcare professionals. And I mentioned that there are different chronic diseases that tend to be more common among women. There's also many diseases that are even more prevalent among ethnic minority women, as we'll look at later in the lecture, high blood pressure being one of them. And I showed you also the life expectancy differences based on ethnic group. And when it comes to poverty and its increased effects on health, ethnic minority women tend to be overrepresented among the poor. So when it comes to being someone who is from an ethnic minority, you tend to be in a much higher risk group. So let's start with one of our regular health issues, the menstrual cycle. The biology of the menstrual cycle is specifically looking at the ovaries, fallopian tubes, where the egg is released. We're also going to look at different areas of the brain that also interact to create the menstrual cycle. So first, ovum is the egg. The follicle is the capsule surrounding an egg in the ovary. And this is where the eggs are created. The menstrual cycle has 4 basic phases. We're looking at the follicular phase, which is the first phase beginning just after menstruation. During this phase, the follicle matures and swells. Ovulation is the next stage, where the egg is actually released. And the luteal phase is the third phase after ovulation. And this is where certain cells, they're called the corpus luteum, they form in the ruptured follicle. And this is important for understanding the feedback loop that happens. And then the fourth phase is the menstruation, which is typically about a week where the menstrual cycle occurs, the bloody discharge from the lining of the uterus that had been built up in preparation for a possible pregnancy. And it is a feedback loop created through the different hormones being released. Now, we have estrogen and progesterone, or hormones you're probably already familiar with. There's also a hormone called the follicle-stimulating hormone that is created by the pituitary gland. And we also have the luteinizing hormone that is part of the responsibility of creating the feedback loop. And so you have the ovaries and the pituitary gland and the hypothalamus and the brain that send out these different hormones and create these signals to create this loop that keeps the menstrual cycle going. So you see the 4 phases here, the follicular phase to the ovulatory phase, the luteal phase, and the menstrual phase. Now, it's created by, like I said, through a negative feedback loop. The follicle-stimulating hormone is secreted by the pituitary gland, and that's what creates the follicle to develop into an egg. The luteinizing hormone is what triggers the ovulation, again secreted by the pituitary gland. We also have a gonadotropin-releasing hormone. This is what's secreted by the hypothalamus to regulate the pituitary gland. So this is what tells the pituitary gland to reduce its particular hormones. So you can see the brain is just as involved as the ovaries in creating these hormones and creating this cycle. Now, the follicular phase is initiated because of the pituitary gland sending out the follicle-stimulating hormone. So that creates the follicles to come to maturity to create the eggs. This results in a high level of estrogen as they get produced to make the follicles mature. And the higher levels of estrogen actually send signals to the pituitary gland to decrease the production of follicle-stimulating hormone and to begin the production of the luteinizing hormone. And so the luteinizing hormone triggers the ovulation. This creates even more estrogen production, which then lowers the follicle-stimulating hormone, and the egg is released. When the egg is released, that's when the corpus luteum forms. Remember, in the luteal phase, the corpus luteum forms in the ruptured follicle, and this is the source of the progesterone. When the progesterone levels become sufficiently high, it creates, through that negative feedback loop, an inhibition of the production of the luteal hormone, or the luteinizing hormone, and also creates the production of the follicle-stimulating hormone, which restarts the cycle. Some different problems that some women experience with menstruation: the dysmenorrhea, painful menstruation. It's cramps that are created to help to flush out the lining of the uterus. Women have a variety of different experiences with their menstrual cycle, including with cramps. Some women experience much more severe symptoms than others. The prostaglandins are hormones that stimulate the muscles of the uterus to contract to help to release the lining of the uterus. So you can use anti-prostaglandin drugs to help to reduce cramps. Now, there's a lot of psychological aspects. I mentioned this with last class about women and girls experiencing personality or mood changes and dealing with the different phases of the menstrual cycle. When you ask people after the fact the information tends to be pretty unreliable. If you ask them in the prospective self-reports, however, there does seem to be small fluctuation in mood and symptoms, but there's no actual research that has proven that hormone levels influence the mood across the monthly cycle. Now, oral contraceptives change the levels of hormones. They maintain high levels of estrogen and progesterone in your system to basically make your body think you're pregnant to keep you from getting pregnant. And this leads to a steady mood, so it could be one indication that possibly mood is affected by the changing hormone levels. PMS is something we're all pretty familiar with, premenstrual syndrome, and this is a combination of the physical symptoms like the cramps and the headaches and the bloating and fatigue, as well as psychological symptoms like what can be experienced as the mood swings and even some mild depression. And it can happen for women for, say, a few days before menstruation. It tends to be pretty vaguely defined, and when you ask women, it doesn't seem to be universal. There's a lot of women who report not having any PMS, and even when they do report having any symptoms, it tends to vary greatly from woman to woman. Other studies have indicated women report more problems when they think they are in the premenstrual phase. If you make someone think that a woman is in her during PMS, they see mood swings even when there aren't any. There's also cultural influences on menstrual cycle mood shifts. When we look at different ethnic groups, there's some different interpretations for how mood actually might be affected. Just overall culturally, we see a lot of different indications that PMS, it varies based on the cultural expectation of how people are supposed to behave. For example, American Indian women believe menstruation is a time of centering and balancing, that the menstrual cycle actually helps them to wash away their impurities and anything negative, and so they actually see it as a positive time. Other groups see it as something shameful or even embarrassing, and so that can affect how people experience the different monthly cycles. Like I said, the mood shift is really dependent on the individual women. When we come to making hiring decisions based on you being a woman and might have fluctuations in mood, we see that it's really not affected that much. Performance is not really affected that much through the different hormone changes. Although there does seem to be some indication that spatial performance is highest during menstruation when the estrogen and progesterone levels are low, and it tends to be positively correlated with women's testosterone levels. So there is some indication in some studies, but in other studies it says that their spatial scores didn't differ significantly from men's in any other studies. So it's not really any consistent research that indicates that there are actually any real reasons to see women as being different or that their performance can be affected based on menstrual cycle fluctuations. And there's even some research that indicates that there is even some evidence that suggests that there might be some sort of monthly cycle for men, although there's no real research into this to see if it actually changes on a cycle just like women's does. Some other fluctuations that happen during the menstrual cycle is some changes to the sensitivity of the five senses. During ovulation is when when women have peak sense of smell. Pain sensitivity also fluctuates across the cycle. During the follicular phase, women tend to be the least sensitive to pain, and so there's some indication that it actually changes physiological aspects. But there's a lot of variability in menstrual cycle mood fluctuations. We can't really show that it's going to affect all women the same way. So there's also some differing views on periods. As I said, culturally, some of them see it very positively, whereas in other cultures it tends to be considered a time of frustration or even something that you have to be embarrassed about or shamed. So I use this commercial as an example of maybe a different way of looking at the menstrual cycle.
Jenny got it. Then stupid Vicky got it. And I tried everything to get my period. Nothing. So, I faked it. Looks like Florida. Yeah, I got it. So red. Gross. What do you think it is?
Just nail polish? But she doesn't need that. We have to celebrate.
No, we don't.
Oh, it's family tradition. We're throwing you a first moon party.
What the hell is this moon party?
It's one by me. Hi. Tea for Janica. Hello?
Dad, people started showing my house.
So cool.
My grandparents? My friends?
This is so weird.
My mom's freaking coworker.
There she is. Hey, I got you a super pack. Friend, you like?
Didn't expect freak.
Oh,
The paddle.
you know how.
I used to like marshmallows. Not anymore.
This next one's for Katie. And the weirdest birthday party ever.
Like,
Everything's worse. My
what are you doing? Missing the magician?
You need to stop this. No one is having fun.
What are you talking about? This party is a hit. Your grandpa is bobbing for ovaries like a champ.
I faked it.
Well, me first. Periods. Get a Grammy. Mine. Do the first. What do you think? Have glitter on.
Sometimes you just gotta wait.
The idea here is that if we had a more positive attitude towards the menstrual cycle, you gotta wonder if people would experience it differently. Experiences of mood swings and even PMS symptoms are described differently in cultures where they have a more positive view. Whereas in our culture, where it's considered such a negative thing, more women experience PMS. Now, premenstrual dysphoric disorder is a very uncommon, much more severe version of PMS. And this is just added to the DSM-5 as a diagnosis. This is where individuals have basically like a major depressive episode that begins right after ovulation and lasts for about a few days into the menstrual cycle. So for about a week to 10 days, the women have a major depressive episode, including intense sadness, even eating issues and sleep issues, and it can cause them to be so depressed that they may attempt suicide. And it can happen every month as their menstrual cycle changes. Now, this does give indication that hormones can affect your moods. So although research doesn't indicate that women are all affected this way, there is some small percentage of women where we do see really extreme mood swings and issues related to the menstrual cycle. I've mentioned some cultural differences. Again, various cultures tend to see the menstrual cycle very differently. There are many cultures where it's considered that a woman is actually unclean. There's even places where they can't enter religious temples during their menstrual cycle because they're seen as unclean. And there's a link there on how to sneak a pad or tampon to the bathroom at school. Our culture tends to see it as a fairly shameful thing as well, something that you're supposed to hide and be very secretive about. So next we talk about menopause. Menopause is where women start to have a cessation of their menstrual cycle. It is a process that happens over time. It's where the ovaries have gradually aged over time, and average age of onset is about 51. It can happen much younger. Some women as young as 40 years old start to experience menopause symptoms. Some women experience hot flashes, night sweats, vaginal dryness, and even depression as their hormones fluctuate rapidly as they go through the different changes. Now, perimenopause is the early aspect of it before full menopause has onset, and this is before everything, their menstrual cycle has stopped. This is when they tend to experience the most severe symptoms. About 50 to 75% of women experience hot flashes, but it does vary from person to person. If you look across different ethnic groups, African American women tend to experience the most hot flashes, with Latino and white women having a very similar percentage, around 26 and 24, but only 12% of Japanese American women experience hot flashes. So it does vary somewhat across different ethnic groups. There are higher incidents of depression. There are no higher incidents of depression during menopause than at other times during women's life. So there's actually a lot of myths surrounding it, that women tend to be extremely moody and that they can't be calmed down, they get very angry, or they cry a lot, and mostly the symptoms tend to be fairly mild for most women. If they do experience some depression, it's usually due to dealing with all of the physical symptoms. Now, different hormonal imbalances can be treated with different types of hormone treatment, like estrogen therapy, where they get replacement doses of estrogen, or other hormone therapy that looks at estrogen, progesterone, and even possibly testosterone to help to treat their changing hormone levels during menopause. But it has to be weighed against its dangers. It used to be considered this miracle treatment until they realized that it also increases the risk for heart disease, breast and endometrial cancers, and even possibly increases the risk of heart attack, stroke, as well as blood clots. So hormone replacement treatment can actually be pretty dangerous to your health. One of the other symptoms it can relieve is the increased incidence of osteoporosis, which is a weakening of the bones, which tends to increase as your estrogen levels go down. Now, like I said, just like what we saw with the cultural differences in how people experience the menstrual cycle, menopause has the same thing. There's been this cultural bias towards expecting women to have erratic, crazy behavior, and that women don't tend to actually have that.
Mom, I'm really sorry. I know you wanted a baby, but I'm not really sure what to say, mainly because I'm not really sure what menopause is. You know, you lose your hair? Shut up. It's not losing anything. This just means that from time to time, a woman's body... Jenny, explain it to the boy. It's getting loose. She talked to Grandma about
just ignoramuses.
Okay, let's go.
Is it like a lady parts thing? World Book.
Memorial Day, meningitis. Okay, here we go. Pause.
Good God, I didn't think they'd have pictures.
Well, at least they use the word uterus a lot.
I could have gone a whole lifetime without knowing they had a mucous membrane.
You can't unlearn something like that, you know? Oh no, look at the symptoms. Temperamental behavior, mood swings, facial hair. Oh, Dad. I do have menopause.
This just illustrates the confusion that many people have over what it's supposed to look like. Most people associating it with irrationality, frequent mood swings, that the person's just unable to deal emotionally. And there's not a lot of talking about menopause or the menstrual cycle for that matter. And because it's such a topic that's taboo, most people don't have a really good understanding of what the experience is really like. So, moving on to contraception. 1 out of 14 women between the ages of 15 and 19 become pregnant every year. 59% of these pregnancies result in live births. 27% of these pregnancies are terminated by abortion. The remainder end in miscarriage. So, family planning really seems to be a very important issue when you're looking at late teens getting pregnant and about 59% of them having a baby, and it makes huge changes to their life. And then also the abortion rate being at 27%, which we'll talk about abortion in a minute. And so part of this has to do with lack of access to contraception. When women are able to practice contraception and space their pregnancies farther apart, we actually see overall it's really good for women's physical and mental health. It also reduces infant mortality rates. So having access to contraception can tend to be really effective at overall improving women's health. Abortion, about 1.2 million abortions are performed in the U.S. 1 in 3 women have had an abortion by the age of 45. Medical abortions are about 16% of all abortions in the U.S. They take a medication called mifepristone in a pill which causes the lining of the uterus to be sloughed off, and it happens within the first 9 weeks of the pregnancy. And this is one way that it can be done very early on. Surgical abortions are the most common. The vacuum aspiration is the most common procedure. It can be done in the first trimester. It is an outpatient procedure. They just use local anesthetic, and it tends to be very safe for the mother. The problems following an abortion are very rare. One of the most likely is a possibility of infection, so being on the watch out for that. But women tend to be under the worst stress before they actually get the abortion as they're going through making a decision. Women are actually much more likely to experience psychiatric conditions in the year following childbirth than they are in the year following an abortion. Adolescents who choose an abortion are more likely to graduate from high school than those who carry a pregnancy to term. There is a political bias that affects the research, though. Poor quality studies report poor long-term mental health outcomes of abortion, but the high-quality studies report better outcomes. And it tends to affect how we see it when the research is getting affected by the bias that is actually being created by in the political arena based on how you feel about abortion. So we can't be as certain as we want about what's the best thing to do in this situation. The long-term consequences, though, of restricting abortion are that there are going to either be women getting illegal, unsafe abortions, or there are going to be women having babies that are essentially unwanted or that they're unable to provide for. For example, 220 children were born to women denied abortion in Czechoslovakia. Following those children over time, they found that they did poorly in school. They were much more likely to drop out without completing school. They had poorer relationships with their mothers and a poorer adjustment in adulthood. If you look, some of them, the boys said that they felt neglected or rejected by their mothers and felt their mothers were less satisfied with them. In their early 20s, they reported less job satisfaction, more conflicts with coworkers and supervisors, and fewer and less satisfying friendships. So the long-term consequences are not just to the mother, but also to the children. Heart disease is a really important condition. It is the leading cause of death for women of all different groups in the United States. You can see cardiovascular disease having some of the highest rates. Coronary heart disease, stroke, cancer, and asthma or COPD are all leading causes of death for women. Compared to men, like I said, women tend to be older. They are more likely to have high blood pressure before the heart failure. They're also more likely to have diabetes and diastolic dysfunction. Diastolic dysfunction tends to be very hard to diagnose, and treatment is very limited. And so women are less likely to receive adequate treatment for their blood pressure dysfunctions. And most of the trials of congestive heart failure treatments have included mainly men, so the medications aren't going to work the same for women. And here's how it changes by age. You'll notice that men are overwhelming the cases of having a heart attack until we hit the 75 and up group, where women actually surpass men. It is the leading cause of death for African Americans, Latino, Asian Americans, Pacific Islanders, American Indians, and Caucasians. In 2007, African American women were reported to be the highest risk for death from heart disease among all racial, ethnic, and gender groups. So it's a serious health concern for all ethnic groups. You can see the breakdown based on men and women in the different ethnic groups, and you can see that Black, not Hispanic, men and women have the highest rates of cardiovascular disease and death. And coronary heart disease is the leading cause of death for African American women, with stroke, lung cancer, and then breast cancer following. And their rates are much higher than for any other ethnic group. African Americans with established coronary heart disease are at a high risk for cardiac death. So when they already have coronary heart disease, where they have clogged arteries or high blood pressure, they're at a high risk for having a heart attack. And their death and morbidity risk from the coronary heart disease is attributed to hypertension, is much higher in African Americans than it is in other groups. So treating the hypertension or high blood pressure is extremely important in African Americans. Latinas have higher rates for many risk factors, though. They tend to have higher rates of obesity, less physically active, a metabolic syndrome, which is a combination of different syndromes that lead to higher risk of diabetes as well as heart disease, diabetes, and high blood pressure or hypertension. Over 50% of Latinas born in the year 2000 are estimated to develop diabetes, and those who have diabetes, their leading cause of death is coronary heart disease. When it comes to Asian Americans and Pacific Islanders, there's a bit more limited information on prevention and treatment. They tend to be a smaller group in research studies, leading us to not have a good indication of how they're going to react to different medications. but also there are many different ethnic groups within the Asian American community, from Japanese to Korean to Chinese, etc. So they are going to react to it differently depending on which group they're a part of. South Asians, like in India, have been reported to have a higher prevalence of heart disease at young ages because of the higher prevalence of that metabolic syndrome. It does vary among American Indian communities. Again, just like Asian Americans, there's many different groups within the American Indian community as well. But this is one group where we see coronary heart disease increasing, whereas we don't see that in the other ethnic groups. Breast cancer is another big concern for women. It is the most common form of cancer for women. 1 in 9 has had breast cancer at some time in her life, so it tends to be very common for women to experience this. Women should complete self-exams mid-cycle. Now, the self-exams you can find that anywhere on the internet about how to perform one of those, and many women have probably been taught by their gynecologist how. It should be done mid-cycle because certain lumps in the breast change according to hormone changes, and so this is when they're going to be less likely to interpret something that is just related to hormones as being an actual lump. But there's psychological factors like fear that prevent some women from doing their self-exams. They don't want to actually they don't want to know. Like, if you find a lump, there are some women who will not actually go to the doctor immediately because they don't want to know that they actually have cancer. Now, survival rate 5 years after treatment is 82%, so it's very successful that many women can get the treatment and survive and be cured. Not all breast lumps are cancers either. Most of them are actually cysts or fibroadenomas. Now, these different cysts can be related to hormone changes or other issues that have absolutely nothing to do with cancer, benign meaning non-cancerous. There are different surgical treatments. The radical mastectomy is where the entire breast, lymph nodes, and the underlying muscles is removed. This is used when the cancer spread to the lymph nodes. A modified version is when the muscles are not removed, just the breast and the lymph nodes. In a simple mastectomy, only the breast and possibly a few lymph nodes is removed. In a partial mastectomy or lumpectomy, they only remove the lump in the surrounding tissue. So it depends on how far it's spread to know how much actually has to be removed, or if they're at a high risk for redeveloping the cancer, they may be more likely to remove more of the tissue. Now, psychologically, a lot of women experience depression and anxiety when they are diagnosed, but they tend to adjust fairly well after receiving treatment. There is the possibility of post-traumatic growth, and this is actually positive life-changing following highly stressful experiences. I mean, you hear of people who have a brush with death and then they suddenly change everything about their life and start to do things differently and end up being happier. And so this actually can lead them to have more positive lives after they have treatment for breast cancer. Just to add into the income issues, although breast cancer is more common among higher income women, mortality rates tend to be higher among lower income women due to not getting the diagnosis earlier. It's a case where being poor can literally kill you. Now, when it comes to support groups, there are support groups for basically everything. Now, there's no real indication that the support groups are actually going to help or improve quality of life, but education tends to be pretty helpful. Education can actually help women to better understand what's going on and can actually provide long-term benefits for the quality of life as well. Now, peer support groups, some people find them useful, some don't, but there's no indication it's going to do much to help. Cervical cancer is less prevalent than breast cancer. Now the cervix is at the bottom of the uterus. This is where the passageway is to the vagina from the uterus. Cervical cancer is caused by HPV, or the human papilloma virus. It is a sexually transmitted virus. You may have heard of the HPV vaccine that is available, and you can get this vaccine and help to prevent the spread of HPV. It is a common infection, though, and only certain strains of it will actually cause the cancer, and most of the strains tend to just kind of go away on their own. Pap screens are tests that test for HPV. They tend to recommend you get this every year, and so that they can find out if you have any signs of this or abnormal cells. Now, not everyone gets the Pap tests. There's actually doctors who don't perform the Pap tests on lesbian women, thinking that they don't have to, that they can't be exposed to the HPV virus since they haven't been having sex with men. But anyone that you're having sex with can actually expose you to the HPV virus, so even women who are lesbians should get tested as well on a regular basis. Poorer women are also more likely to avoid getting tested, avoiding the cost, and so there's actually huge ethnic disparities in cervical cancer incidence and death. Latinas have the highest incidence, and black women have the highest death rate from HPV. Now, some people have some concern about the stigma associated with it because it is sexually transmitted, and that may be one reason that people may be less likely to get screened as well. I just said that. Like I said, there are vaccines. Some states are starting to require vaccinating girls, but not boys. But both girls and boys can get the vaccine to help to prevent. And it does help to prevent other issues for boys. HPV can cause penile cancer as well. And so being aware that males should be protected, not just women. But it brings the question up of vaccination encourage sexual activity. And my personal belief is it doesn't, but it's everyone's own choice on whether they should get their teens vaccinated or not. So now we have ovarian cancer. Ovarian cancer is rare compared to breast cancer, but I wanted to mention it because it has the highest rate of death of all gynecological cancers, because it tends to be a silent cancer. Most of the time, by the time it gets diagnosed, it has already spread. And so it's really hard to test for and to be aware of. When you have cancer of any of the internal reproductive structure, you may receive a hysterectomy to remove those. There's also an oophorectomy to remove just the ovaries. I did mention that 70% of all hysterectomies are not necessary. So some women do experience getting these done when it isn't needed. Next, we're looking at osteoporosis. This is a porous bone. It's a devastating disease where you lose your bone mass over time, as you can see in this picture, and it leads you to have weakened bones. Now, looking at some different myths, osteoporosis is not serious enough for me to worry about. Well, that's a myth. It is a progressive disease. It irreversibly weakens bones. You cannot build them back. Any movement or bump can actually cause you to break a bone once they're that weak. It causes chronic pain and can lead to being disabled. And hip fractures can actually cause death. Another myth is that I'm a healthy person. I do the right things, so I'm not at risk. All women are at a high risk, especially after they hit menopause and their hormones change. I'm too young to worry about osteoporosis now. It's never too early to prevent it. It can strike at any age. You're only a higher risk at menopause Not that it can't happen to you when you're younger. It is living, growing tissue that constantly rebuilds. So you can build up bone mass now, helping to make you more resistant later. Or it's too late for me to do anything about osteoporosis. It's never too late. You can keep it from getting worse because it is a progressive disorder. 80% of cases are women. 1 in 2 women, that means 50% of all women will experience osteoporosis, and 1 in 8 men over 50 years old. More than 28 million Americans have osteoporosis currently. It creates a variety of different fractures, including wrist and most dangerously hip fractures. You'll also see small vertebral fractures that can lead to that humpback. 25% of osteoporotic hip fractures result in long-term nursing care. Half of these people are unable to walk without assistance, and they actually have a 24% greater risk of dying within 1 year. When you have a hip fracture, it makes you bedridden, which makes you more likely to develop blood clots and pneumonia, which puts you at a high risk of dying from a hip fracture. This is, I mentioned, the humpbacked type of view of the spine. Those minor fractures in the spine, you can see, cause the bones to compress, leading to that hunched over positioning. Being female, thin or small-framed, low body weight, or a smoker, as well as advanced age, having a fragility fracture, or a family history of osteoporosis, all put you at the higher risk of having osteoporosis, as well as postmenopausal. As I said, the hormone imbalances and reduction in estrogen can lead to bone loss. Women can actually lose up to 20% of bone mass in the 5 to 7 years after menopause. Hispanic women are at the highest risk. They tend to have the highest rates of osteoporosis. You can see 36 to 49% of Mexican-American women have experienced significant bone loss. The next group of risk are Caucasian and Asian American women. Although African American women have a somewhat lower risk than other ethnic groups, they do still have concerns of having low bone density, which can lead to fractures. 80 to 95% of all fractures suffered by African Americans over 64 are from osteoporosis. And African American women are the group that are more likely to die from hip fractures, so it is still a concern. Your risk of hip fractures doubles approximately every 7 years. And when it comes to African Americans, part of the reason they're at the higher risk is 50%, they consume 50% less calcium than the recommended daily allowance. And so because higher rates tend to be in the lower income bracket, they're less likely to have access to proper nutrition. I believe our last condition we're talking about is HIV. It is the human immunodeficiency virus. It is a retrovirus, which is unique. It actually invades the immune system of the individual, our T cells. It actually is a global epidemic right now. It is preventable. It is even manageable. People are living much, much longer lives with it, but it is not curable yet. HIV can eventually develop into acquired immunodeficiency syndrome, or AIDS. And when AIDS develops, it limits the body to fight infections because of the reduced helper T cells that have been invaded by the virus. And they end up with a very weak immune system, which makes them likely to develop opportunistic infections that they can't fight off, which can lead to death. The opportunistic infections rarely occur without the severe immunodeficiency or the weakened immune system. The pneumocystis pneumonia and central nervous system lymphoma are only typically seen in someone who has AIDS. And once they have a specific low lymphocyte count, that's when they are considered to have AIDS. So HIV and AIDS are essentially different progressiveness, different levels of progression of the disease. You can get it through bodily fluids like blood products, semen, and vaginal fluids, through sharing needles that haven't been sterilized or unsterilized razor blades, unprotected intercourse, oral or anal, as well as the mother can transfer it to the baby during birth or even before birth. There are myths. You can do most everything you normally could do with other individuals, eating together, working, shaking hands, and you won't get HIV. Even in a very short span of time, if the blood sits and dries, it won't be transmittable either. The largest group in 1985 that were getting diagnosed with it were men who have sex with men. That's the MSM. Now, although they make up almost 50% of it, the heterosexual population is making up nearly a third. Intravenous drug users are also a pretty decent percentage. Other groups include individuals who maybe got occupational exposure or had a tainted blood transfusion, although you'll notice that group has gone down because of protective measures. In the first stage, when you just become infected with HIV, you may have a short illness that's like flu that happens about 1 or 6 weeks after you get infected. Very mild symptoms. You probably just think you have the flu, and you can infect another person during this time. And then the next stage, you spend asymptomatic, not having any symptoms. It lasts on average 10 years. You might have some swollen glands, and you might find that the HIV in your blood levels drops. The antibodies are detectable, but their levels are very low. In the third stage, you become symptomatic, and this is when the immune system deteriorates. This is when the infections and cancers start to appear. And stage 4 is when you move over to AIDS, when your immune system weakens so much that you hit that decreased level of lymphocyte number. At this point, you get bacterial infections, tuberculosis, different herpes viruses, vaginal candidiasis, the hairy leukoplakia, and Kaposi sarcoma, which you see pictured there. Kaposi sarcoma is one of those conditions that you typically only see in someone who has AIDS. Tuberculosis tends to be the most common opportunistic infection and one of the main causes of mortality in patients infected with HIV. There are 10 million people in the world who are co-infected with both. Now, the immunosuppression, or the weakened immune system, how it looks because of the HIV, actually makes TB look different, which can lead to individuals not receiving effective treatment. Now, you can be tested anonymously. They don't use your name, only a unique identifying number, and you're the only one who receives the results. The ways to protect yourself include abstinence, staying in a monogamous relationship, being sure to have protected sex, only using sterile needles, and not sharing any sort of shaving razor blades. It is an escalating epidemic. People are living longer, so you'll notice that the number of people living with HIV is growing and growing. There are people newly being infected every year. This is around the world. 24% of all AIDS cases in our country are women. Like I said, it is increasing among the heterosexual population. 8% in Hawaii are women. Worldwide, more than 40% of all adult HIV infections are women, and they are 75% of all new infections. There's many areas where women are not safe and they are at risk of being raped and leading them to get infected. It is an issue that is different for different ethnic groups in our country. The much higher rates found in non-white populations, African American, Asian, Latino, Native American populations in our country. Across the world, you can see that sub-Saharan Africa and South and Southeast Asia have some of the highest rates of HIV. Sub-Saharan Africa is partly due to the war-torn areas where we're having many cases of women being raped or refugees being attacked. South and Southeast Asia partly has to do with the Hijras population being exposed to sexually transmitted diseases as sex workers. These are the newly infected cases, highest percentage in Sub-Saharan and Sub-Saharan Africa and Southeast Asia. It is also an escalating epidemic in Pakistan. Pakistan is another area that is unstable currently, and they're seeing strongly increasing rates among their population, especially IV drug users, homosexuals, and third gender individuals like the Hijras in India. There are huge amounts of sex workers who do not have safe sex awareness in Pakistan, as well as a huge number of IV drug users, and 1 in 5 of those are infected with HIV, as well as homosexuals. They also don't have annual blood donors screened for HIV, so there is the possibility of blood transfusions being containing HIV. And there are some people who are professional donors who have a high prevalence of infectious diseases. They are professional donors, meaning that's how they make their money, is by donating blood, as well as large numbers of migrants and refugees who are a high-risk population for being raped or exposed to different diseases. Initially, many people are shocked. They're afraid when they get their diagnosis. It can be very surprising and unnerving. It also creates a lot of fear, but it isn't a death sentence any longer. It also will affect their sexual identity and behavioral choices. They may not feel like they're safe to be around their sexual partner. They may feel undesirable, and they may fear their eventual dependency on some others once they develop AIDS. Race and ethnicity are also important. When you look at U.S., African Americans make up 65% of AIDS cases among women, and they are not 65% of the population of women. So they are at a much higher risk of being exposed to HIV. It does tend to be transmitted differently in minority populations than it is among whites. Now, some of it has to do with some of the inequalities in power between women and men when it comes to how it gets transmitted heterosexually. And according to the social dominance theory, these gendered power inequalities are rooted in men's violence against women. Men tend to have higher level of control over resources like financial or economic ones, and women tend to be more responsible to other people, the different gender roles and the stereotypes, and this leads women to be at a higher risk to be attacked sexually or be forced sexually to engage in an act that they don't want to be, leading them to be exposed to higher risk of being exposed to a sexually transmitted disease. Alright, that's the end of the show. After watching this video, don't forget to write me an email of something you found interesting from the lecture, and I'll give you credit for attendance.